topic which not every faculty can actually speak. And the only one name that came to my mind the moment I thought of this particular topic with an input from all of you is Professor L.M. Darlong, because there are very few people who have a passion to thoracic surgery. It's easy to be in head and neck or GI or gynae onco or robotic alone in esophagus and other. But having a special interest in thoracic and excel, very few people are there in India, and you need to hear from an expert who are great in that, teachers, very senior people, and servicing in a very good multi super specialty teaching cancer hospital. So it's our honor to welcome Professor Dr. L.M. Darlong. He's MS from All India Institute of Medical Science. Then he went on to do fellowship in thoracic surgery. He heads the thoracic oncosurgery at Rajiv Gandhi Cancer Institution here. More than anything, not just the esophagus, lung, mediastinum, thymus, and other. He's great in VATS, minimal access, as well as robotic surgery. And he has done a lot of work in India on the pectus deformity. You need a lot of grit, challenge to do this. He has several publications in this, and is an excellent surgeon, excellent teacher, and an excellent human being. So I request all of you to optimally utilize this, the precious time Professor Darlong is giving to all of us from his busy schedule OR work for all of you. And please make absolute use of this. At the end of it, if you have any question and doubts, put it in Q&A or chat box. Thank you very much. Over to you, Professor Darlong. Welcome.
Good morning. Thank you, Dr. Shom, for the kind words. And I would really thank you and the team for having formed this idea of an NBE for the DNB students who are usually left behind when compared to their colleagues in other institutions. So the topic today is basically on lung cancer, applied surgical anatomy of lung, lobar segmental application and algorithm. And I'll talk about the recent advances, which are very much applicable to us at the end of the talk. So first we go to the applied anatomy of the lung. This you can see is an image of the lung from the left to right. If you see, it's what is seen from the anterior aspect, the lateral aspect, and from the posterior aspect. So if you see as such, this is the reason why we do our lung surgeries in the lateral position. And it is preferable to be on the medial side of the, facing towards the patient, that's towards the medial side. That's because this is from where all the important hilar structures come out, and you can have access to basically these important hilar structures which come out directly from the heart. You have got a good control. And posteriorly, we have got the inferior pulmonary vein, which is the easiest one, I think, in terms of controlling it. Because once you trace the inferior pulmonary ligament, you are basically bang onto the inferior pulmonary ligament. So you can basically access it in the lateral position from the medial side by just flipping the lung towards you. You can see here in the image. So that's the basic idea of operating in the lateral decubitus position and standing towards the patient. You can see that right side we got the upper lobe and middle and the lower lobe, and the left side we got two lobes, upper and lower. This is based on the fissure, that is the oblique and the horizontal fissure on the right side. So if you see, the importance of the fissure is that it is in the center of the fissure that you find basically all the intersegmental arteries and the divisions coming up, as well as the segmental, the bronchial division into the lower and the middle. So it's important that we know exactly where our fissures are, because once we know where the fissures are, we are basically going in that very much intercostal space, neither too low, too high, but exactly somewhere around that area. So if you trace it posteriorly on the right side, it starts at the level of the fifth rib, which runs down forwards along the sixth rib and ends in the diaphragm along the sixth costochondral junction. So it's basically an oblique line. And the same way on the left side, we got the oblique fissure. It begins much higher posteriorly along the third and fifth rib. It again runs down forwards and ends in the sixth or seventh costochondral junction. On the left side, we got the heart. So we've got less space, and so our axis tends to go more behind, more posterior, more towards the posterior axillary line compared to that on the right side. And if you can see, this is basically the variation of the fissures. if you can have a complete fissure, and that's very, very, ideal cases to start with when you're doing a lobectomy or a segmental dissection, because you're basically bang onto the pulmonary vessels, artery, and you can basically see the divisions. And sometimes the fissures are not complete, and this is especially true in the horizontal fissure between the middle lobe and the upper lobe, along with in the junction with the anterior segment. This is a site. Invariably, the fissure is incomplete. It is fused. It's not complete. Then you can have some accessory fissures, like this is also known as accessory lobes, which are made of bronchopulmonary segments. They've got a separate bronchopulmonary divisions along with a segmental arterial division, but not a venous supply in that. So it's basically a bronchus with the arterial system. So we can have on the right and the left both posterior, inferior, and middle lobe of the left lung. These are the true accessory fissures. Posteriorly is basically on the right side. It is basically your superior segment of the lower lobe. You can have an accessory fissure there. So having an accessory fissure there makes you basically do a fissure segmental dissection much easier. Inferior is basically your medial segment of the right lower lobe, and middle lobe on the left is basically the lingular segment, which will be again into two parts, the superior and inferior part. It's but mainly the lingular segment. And azygous lobe, which you can see on the right side, is not really a true bronchopulmonary segment, because it's basically because of indentation by the azygous veins that it is compressed. So this is not a true accessory lobe. It is more of an importance in terms of CT finding and more of an injury that we see on during surgery. These are the images of the accessory lobes. Now coming to the bronchopulmonary segments, the lung after the lobes again divided into bronchopulmonary segments. We got 10 on the right side and 9 on the left side. This is for the purpose of calculating the lung volumes and PPO, FEV1 that we do some in pre-op cases. So on the right side, right main bronchus divides into right upper lobe, middle lobe, and the lower lobe bronchus. Upper lobe again segmentally is divided into apical, anterior, posterior. From apical, posterior, and anterior, we call it as S1, S2, S3. We call it segment 1, segment 2, segment 3. And the right middle lobe again is into lateral and medial, which we say numbered as S4 and S5. And lower lobe bronchus again is divided into 5 segments. We count as apical, anterior, posterior, medial, and lateral segment. That is S6, 7, 8, 9, 10. So we've got 3 segments in the right upper, 2 in the middle, and 5 in the lower on the right side. And if you go to the left side again, the left main bronchus, it is more longer in the side, more about 4 centimeters. But most of the part is hidden by the arch of aorta, which makes the dissection or surgery in the left main bronchus near the carina much difficult compared to that on the right side, which is usually just in front of you. So on the left, again, the upper lobe divides into upper and lower branch, and it again divides into apico-posterior segment. We call it the S1-2, and the anterior segment, which is S3. And we have that lower division of the upper bronchus into superior lingula and inferior lingula as S4 and S5. And in the lower lobe, you've got again 4 segments, not 5, because we got a heart on this side, so we don't have the medial segment in the lower lobe. So it's S6 and 7, 8 we call it combined, or 8, and then 9 and 10. That's the posterior. So this is the diagrammatic representation of the tracheobronchial tree. You can see here that the right trachea is shorter, about 2 centimeters, and it is more in line with the trachea. And this is one of the reasons why you can have more of aspiration on the right side compared to that on the left side. And you can really see here, again, the applied part of this is that since the main bronchus is shorter on the right side with the right upper lobe taking off early, this is one of the reasons that anesthetists always put a double lumen tube on the left side, because they got more space to put the tracheal part, the bronchial part of the tube on the left side, which if you use the right tube, there's more chance of blocking your opening in the right upper lobe bronchus. This is the rationale behind using a double lumen tube, which is mainly left-sided. This is just a diagrammatic representation of the bronchopulmonary segments. We already seen about it. And this is again the arterial system. You receive the arterial system from the pulmonary artery, which in most of the times is basically the hilum is intrapericardial, and then it comes out just anterior to the right main bronchus and divides first, which supplies the upper lobe as truncus anterior. This is the truncus anterior, which is the first we usually encounter when you are dissecting around the hilum in the superior part. So this truncus arteriosus arterial divides again into two branches supplying the apical segment and then the anterior segment. And just below it, you might have you will have a smaller one that's basically the posterior ascending branch, which supplies the posterior segment. This branch is usually very, very small. And when you're doing upper lobectomy, it's important that you try and find it out because it can be injured because of the small size of it when retracting and all that. And any bleeding we know from the pulmonary arterial system is always a high volume, though it's a low pressure. And whenever you have a bleed in a pulmonary artery, we should not try to go and catch it immediately. It is basically because of its low pressure and high volume that you see sudden gush of blood. But if you put pressure with a gauge or a swab, usually you can have, they can get controlled, especially the smaller ones, and then you can have time to think about it and go in again and then take out that vessels. And so lower down on the right side, following this, we have the branch to the middle lobe, which can be single combined lateral and medial, or two separate branches to the middle lobe as a medial and a lateral branch. And at the same level on the posterior aspect, you will find a branch to the right lower lobe superior segment, that is segmental bronchus, and basilar branches, other ones usually arises as a common trunk just before they divide, and it's usually in this common side that we can easily ligate. So we have to take most of the times the basilar branches separately and the apical branch of the lower lobe separately. If you see on the left side, this is again the pulmonary artery has got a longer course. You have got a longer course of the pulmonary artery on the left side, and it is for this reason. And you can easily loop the pulmonary artery on the left side. When you think that you're going to have some amount of bleeding, it's important that we just loop it so we have got a proximal control. And left side of the lung is one area where you got multiple branches to the upper lobe. They all are quite small except the ones like apical posterior branch and the anterior branch. Then comes the lingular branch. So the number can vary, but invariably we will find at least 4 arterial supplies, and sometimes you can get more than that. And so we have to be very meticulous, especially in doing the upper lobes. And as I said, since the pulmonary artery has got a long extra pericardial component, so we can loop this area and have a proximal control every time you feel that you're going to have some issue with terms of bleeding and dissection. And again, as in the right side, this continues as the basilar branch and behind as the superior segmental branch of the left lower lobe. Only thing in the left side is that because of this multiple branches supplying the left upper lobe, you have to be more careful in dissection and then controlling the vessels. This is a more closer look at it. You can see here. So the pulmonary vein, which is more easily seen and more easily dissected, is basically more superficial. It is the most superficial part. It's located anteriorly, unlike the pulmonary artery, which lies behind the pulmonary vein. You can see here, these are some of the variations in the pulmonary circulation. I would just focus on one, that's basically the C one. You can see here that most of the time the branches are occurring early or late or long intrapericardial, extrapericardial, or accessory, coming out basically from the hilar area only. But sometimes on the left side especially, you can have a common pulmonary venous trunk. Like in this image you see here, you can see here, this is the pulmonary artery. It is seen very easily. You can see here, this is the hilar node. And you can see there's a big tissue here, thickened tissue here. And this should have been somewhere where the superior pulmonary vein is here. But it's not seen here. You can see it's more of a common trunk here. You can very easily see that something is going towards upper lobe and other towards the lower lobe. So if you dissect further, you can see that this is the common pulmonary venous trunk on the left side. So it's important that when you're doing a left lower lobectomy, you should always try and confirm that you're not having a common pulmonary vein. So this is the way you can basically easily separate, and then you can basically take off whichever superior part of the lower or the inferior part based on the lobe you are dissecting. And again, not very commonly described in the textbook. Since we know that lymph node dissection is an essential component, especially level 7 in lung cancer surgery, we might sometimes encounter, and it's important to know that we have to be very sure that you are not basically just going buzzing in this subcranial area with our harmonic scalpel or other instruments, but we should be dissecting it carefully to see for any anomalies. Like in this case, we are seeing a anomalous pulmonary vein in the subcranial area. It's basically, this is the anomalous pulmonary vein. It's draining along in this subcranial space. After we dissected all the lymph nodes, we can very clearly see this is the vein which is supplying basically towards the lower lobe or apical segment, or maybe in the superior segment or the middle lobe. We cannot exactly say about it. It's important that we be careful about this, because if we injure this, you'll have torrential bleed, and there's also a likelihood it might just retract interpericardially, and it could be a catastrophe. This is just to show the image of that. This is the anomalous vein, and this is the right inferior pulmonary vein. This is the pericardial surface. This is the right main bronchus, left main bronchus, the subcranial space. So after having known about this, I think at the end of this talk, we should be able to basically specify where the lesions are there in the lung. This is especially important when you're doing a metastasectomy. As we all know, in soft tissue sarcomas and any malignancy, the lung is the most common site for a secondary, a metastasis. So it's important that you should be able to specify exactly in which segment of the lung the lesion is located, because in that way, it helps you map in your mind anatomically where is the site of the lesion, and you can basically trace it back to your radiology, the CT scan. So in one way, it helps you basically when you're intra-op that you know that this is at this site, this is where you should look for, and very much sure about the location of the lesion. Now, having talked about the prevalent anatomy, we will now come to the surgical management, the algorithm in terms of its management. So to start with, I'll just go about to the TNM staging, which is the basic of any cancer surgery in lung. This is just to show you some of the changes in the 8th edition of the TNM staging. The red ones are the ones which are showing some new changes. If you see in T1, it is basically now less than or equal to 3 centimeters. Now every centimeter of the lung tumor size counts: 1 centimeter, 2 centimeter, 3 centimeter, 4, 5, 6, 7. So now with every centimeter does count. So size is very, very important. And we have now in T1, T1A MI, that's a minimally invasive carcinoma, which initially we used to be knowing as bronchoalveolar carcinoma. It is now a minimally invasive carcinoma. In T1 A, B, and C, it's basically 1 centimeter or less, more than 1, and or less than or equal to 2. 1 to 2, 2 to 3. And again, T2 is basically from 3 to 5. Involvement of main bronchus without carina. We don't really, regardless of its distance from the carina, it should not involve a carina. That becomes T2. And again, T3 is again from 5 to 7 centimeter. And tumor involving the chest wall, phrenic nerve, or satellite nodules in the same lobe of the lung. More than 7 centimeter is basically now T4, and they've included diaphragm in T4, which previously was in T3. And if we see end staging, N1, N2, N3 are still the same. For M, metastatic disease, they've added M1B, M1C. So I think now you can see the importance of metastasis being classified: good metastasis, borderline metastasis, and bad metastasis. So I think this has definitely got some implications, which we'll talk about it in this talk. M1B is single extrathoracic metastasis, including one single non-regional node. M1C is multiple extrathoracic metastasis in one or more organ. So this is just a comparison of the 7th edition and the 8th edition. I think we are all aware about this. I would not really go in deeper more in this. So when we come to a diagnosis, first is the tissue diagnosis. It's very important that we have a tissue diagnosis. We'll be seeing most of the time that we get a report saying FNAC shows this, that, and suggestive of this. Nsclc adenosquamous. But it's important that as a surgeon oncologist dealing with lung cancer, it's now important you get a good tissue. The initial tissue is the most important. We need a good core needle biopsy, either CT guided or using a bronchoscopy or EBUS guided. The tissue should be adequate, that you should be able to run histopathology, including IHC, that's basically TTF1 and P40, which helps you identify adenos-CA from squamous. And very, very more important now is about molecular testing. We need to have some amount of tissue because in the future and now in some studies and all, we are doing a molecular testing to rule out patients who are going to undergo immunotherapy or target therapy as an adjuvant or maybe even the neoadjuvant setting. So this helps us classify the molecular profile also. You should have a good tissue to run this tests in the beginning. So in principle, any lesion which is central and resectable on a CT image, you should try to get a bronchoscopy that is basically more of an EBUS guided biopsy along with mediastinal staging. Lung cancer surgery, if you see, the workup is very, very long. So it's important that we reduce our invasive investigations to the minimum. So in central resectable lesion, when you think you're going to be able to resect, it's important that at the first instance only you get a biopsy, as well as try to get a staging done at the same time of the mediastinal. So clinical staging, this is what we use routinely now, the whole body PET-CT combined, integrated PET-CT. When you don't have this, you can use the CT chest plus abdomen along with the bone scan. The role of MRI brain is definitely very, very important now. I think all cases of Nsclc should get an MRI brain, contrast MRI brain done now with a changing scenario in the management and with metastatic disease being very, very high and prevalent. And they're being treated now with various novel agents in our kitty. So pathological staging, M staging, it's important that biopsy should be done from the most accessible peripheral site and not from the primary site, but try and basically disprove that this is not a metastasis, it could be something else. Because it is not uncommon, but we do come across in India especially that it turns out to be tuberculosis in some cases. You have multiple bony lesions, soft tissue, nodes in a peripheral site, and you do a biopsy, they turn out to be tuberculosis in some rare cases. And staging using the EBUS or EUS bronchoscopy. The EBUS scope is again used as a endoscope from the esophagus, then EUS FNA. Then we have the mediastinoscopy, VAMLA. I will not talk in details about this. Coming to the role of MRI in brain staging, it's important that we can have about 8.3% silent metastasis, especially in adeno-CA. So if we see the current recommendation, NCCN says all should be done except stage 1A up to 3 centimeter N0 and peripheral located. The BTS and the NICE guideline says all cases should undergo MRI brain. SCCP and says it's basically for stage 3 and stage 4 and those with symptoms of CNS symptoms. This is the algorithm, the ESMO chart, which is basically under press. It will be released shortly from 2021. You can see here that they have seen in the workup that CT and PET-CT of the system, along with, you can see here when the mediastinal lymph node is negative, if the lesion is clinically N0 and peripherally located tumor, outer third of the lung and tumor is less than 3 centimeter, we can go basically straight forward for a surgery. And surgery should be preferably a lobectomy. So clinically N1 or central tumor or more than 3 centimeter, mainly adeno-CA with a very high FDG uptake, it's important that a tissue conformer of formation of the mediastinum should be done using EBUS preferably as the first modality because of it being less invasive, and try and prove the mediastinal lymph node being as negative and then proceed with surgery. If on a PET-CT you find the mediastinal lymph node is positive, it's important that we go and confirm it with an EBUS or a US or in the next modality based on that. If it's positive, in that case, the patient goes for a multimodality treatment. We have to discuss it and consider about dissectability, neoadjuvant chemotherapy, and then for further future surgery. And if the mediastinal nodes are negative on EBUS and US, but they are positive on the PET, so they consider doing a VAM lab to prove it on table that it is truly negative. So if the mediastinal nodes are positive, again, they go for multimodal treatment, and if it's negative, they again go for surgery. And this is basically to show the risk assessment for such cases who are to go for surgery. This is the chart. You can see in here in both that the complete PFTO, there is a complete pulmonary function test with DLCO should be done. If the FEV1 and DLCO is more than 80%, in that case, no further test needs to be done, and the patient can go straight for surgery and control and can tolerate to the extent of doing a pneumonectomy. So pneumonectomy should be avoided in as far as possible, but these are the cases who can tolerate pneumonectomy and they did no further testing. But those which are less than 80, you need to further go and do some testing. So once you do the surgical dissection, this is what you will basically get to know about in terms of the stage. The stage 1B and 3A. So stage 1B and 3A are the ones in which you have some form of adjuvant treatments. You can see after doing R0 dissection, for any tumor which is more than 4 centimeter, basically 4 centimeter is the cutoff T size, they all go for adjuvant chemotherapy. And any node which is positive should receive adjuvant chemotherapy. For R1 dissection, presently we have port, and port should be given along with adjuvant chemotherapy. And again, the new one that we have now is that for patients who are completely resected with EGFR mutation in exon 19 deletion and exon 21 L858R mutation, these are the candidates who can receive adjuvant osimertinib. We have the DFS data at the present time, though we don't have the OS data of osimertinib, but it has shown commendable results in terms of basically preventing, giving a disease-free survival as well as preventing CNS recurrence. So if we come to surgery, the basic principles of surgery in oncology is that remove the entire tumor with adequate margins of normal tissue along with the regional nodes. This is what we've been following. So if we see historically, the first long-term survival of lung cancer was achieved with a left pneumonectomy in 1933 by Graham and Singer. They operated on a 48-year male gynecologist who went on to survive for 30 long years. And this is very commendable. So if we see again after that from 1933 to 1950s, most of the cases was basically pneumonectomy, which was considered the standard of care. But though, if you see the data, if they see from 1933 to 1950 from Massachusetts General Hospital, the 30-day mortality was very high in pneumonectomy. It was 23% compared to 14% in lobectomy. If we see the survival 5 years, 12% in pneumonectomy, 19% in lobectomy. You can see here clearly there was a survival advantage of a lobectomy. But those are the times when, in the era of Halsted, radicality was the prime aim. So this was not really accepted by the community. So it continued to be the standard of care in those times. But this gradually changed from 1962, when there were a retrospective review by Sikkim et al. From the National Cancer Institute, who looked into survival data of such cases. When he compared 116 lobectomies over 402 pneumonectomies, he observed that there was equivalent prognosis in terms of localized disease as well as localized disease after comparing with lobectomy. So following this, gradually it became accepted. Lobectomy was getting more and more accepted, and then gradually now we are in the area where lobectomy is basically the standard of care. So for a local control point of view, you can see that we have gone from wedge, segment, lobe, or pneumonectomy, or if I say we had started with pneumonectomy and lobectomy, we are now in some areas segmentectomies and wedge in some cases. And again, a regional control, that's both therapeutic and diagnostic or staging, which helps in we are doing basically a lymph node dissection, a mediastinal lymph node sampling, or maybe a nodal biopsy. This is the study by Ginsberg, the lung cancer study group in 1995, basically for T1 and 0 non-small cell lung cancers, about 276 patients. The first randomized trial comparing lobectomy with a sublobar resection, which is a limited resection. In this study, they found that there was a threefold increase in local regional recurrence when you compare with lobectomy. That's the limited resection. That's a wedge or a segmental resection. So this is the basic study which changed that in lung cancer, lobectomy should be the gold standard and the minimum should be done in terms of local control. However, there were limitations in this study. About 30% of the tumor were more than 2 centimeters. And the resection was varied because some had done just wedge resection with no lymph node dissection. And it was being used even for non-peripheral lesions. So the margin was in doubt. There are 2 trials which are basically trying to show equivalence of segmental resection with lobectomy. These are 2 non-inferior trials. This is JCOG 080, which has already been published and presented in ATS this year. I will talk about it later. And the other CalGB, which is still undergoing, this is comparing lobectomy with sublobar wedge and segmental resection. The first one is basically lobectomy with segmental resection. This is expected to come out. This is from North America. Now we'll go to the very, very most important topic, that's mediastinal lymph node stations. If you see, this is the ISCLC map of the mediastinal lymph node. We are all very familiar with it. Just again revise the entry staging. You can see the entry basically is the contralateral mediastinal or the supraclavicular nodes, anterior supraclavicular nodes. N2 is basically the superior mediastinal, outer nodes, and inferior mediastinal. N1 are the hilar or peripheral. This is basically intrapulmonary. This is again the image. You can see the borderline is on the left side of the trachea. It is not in the center. These are the 2R and 2L. If you see, 1 is basically supraclavicular, 2R and 2L. 4R, you can see from here, the 2R, the superior border of the superior border is the upper border of manubrium. Inferiorly, it is the intersection of the caudal margin of innominate vein with the trachea. And 2L again is the superior border is formed by the upper border of manubrium. Inferiorly, it is formed by the superior border of aortic arch, and the boundary is on the left side of the trachea. 4R, very important. You can see here the upper margin is formed by the lower border of 2R, and inferiorly we have the lower border of the azygos. This is to the extent, and on the lateral side is basically the left border of the trachea. The 4L again on the left side of the tracheal border. These are difficult areas to access using VATS. They can be accessed mostly on the mediastinoscopy. Superiorly, aortic upper border of aortic arch. Inferiorly, you have got upper border of left pulmonary artery. These are including the nodes medial to the ligamentum arteriosum. So these are level 5 and 6. We see it on the left side, also known as subaortic level 5. This is lateral to the ligamentum arteriosum, lying on the aorta, left pulmonary artery, till its first branches arises. 6 is the paraortic, and it's associated, which is nodes along the ascending aorta and the phrenic nerves. So this level 5 and 6, we usually take it as N block. The same way on the right side, we usually take this lymph node packet of 2R and 4R as N block, because that's how you have a good oncological clearance. And we have the prevascular 3A and the prevertebral 3T. This is the level 7, which is more easily accessible on the right side because it is just lying exposed there. On the left side, it is more deep because of the presence of the aorta and esophagus deep down. So it is more deep on the left side. Level 8, we know it's paraesophageal. Level 9 is basically the nodes along the inferior pulmonary ligament. Hilar or interlobal succinate is from 10 to 14. The level 10, that's the hilar, they lie along the main stem bronchus, hilar vessels, and the right side azygos lower border is the upper border to the interlobal branch. So we will go into the anatomy of the mediastinal station. This is the real-time view. You can see this, the image from that's the vagus nerve you can see. And you have to mobilize, this is the level 9 area. And this is a subcarinal area on the right side. You can see it's a big space. You can see very clearly, which is not true in the left side. In the left side, again, this is the level 5, 6 area. So we take this whole area as one packet. And there you can see the inferior pulmonary vein, left main bronchus, and I'm dipping there. That's a subcarinal area. So here it's basically hidden, unlike in the right side. So mediastinal node staging, and various methods I've talked about: EBUS, EUS, mediastinoscopy, VATS, and VAMLA. I will not go into the technical details of this. We all know about this. But I would like to share about the N2 categories. There are various categories of N2. It's a heterogeneous group. When you say N2, it means various groups. You can have occult N2. This is when you have a positive N2 at surgical pathology. After you've taken out the specimen, you have a surprise node, despite the best of effort at preoperative to stage the disease. So these are basically the occult ones are microscopic mediastinal disease, which means the tumor aggregate ranging in size from 0.2 to 2 millimeter in size. Then we have got discrete nodes, which are basically, you can see on the image, we say, oh, this looks resectable. I mean, it's well defined, it's discrete, it's a distinct node, which may be normal or enlarged, and there's no invasion of the surrounding fat or any of the vessels. So these are the ones which are potentially resectable, and you need to go and basically do a proper EBUS staging or a pre-op staging. And again, you've got this group that is bulky. You see that there in the image, you see how the size is big. In the short axis, it may be more than 2 centimeters as per SCCP guidelines and more than 3 centimeters as per NCCN guidelines. You can see from the look of it itself, there is a very big doubt in my mind that can go and take and resect it. So these are most of the times basically not resectable. These are bulky nodes. And again, just the look of it says, okay, I am not resectable. It's basically infiltrated the whole area. You have basically no margin to work. So in such cases, these are the ones which do not require any pathological confirmation. So mediastinal lymph nodes in lung cancer surgery. This is a very hot, used to be a hot topic. I think now it's not normal that we should accept. It's something that we need to do it. So going to the extent of mediastinal node clearance, it can be just a node biopsy. Some people do a sampling, and it can be a mediastinal lymph node dissection, MLND, which would be the preferred one. If you see in the image here, in a biopsy, basically we're just taking a piece of the lymph node. We are not considering any margin. We're just taking a tissue from the lymph nodes. When you're doing sampling, you are trying to take out the lymph nodes intact at least. But when you do a dissection, you are not targeting the nodes. You're basically trying to take out the nodes within a packet that is in a particular pocket. So you're taking the whole packet of tissue, the fat with the tissue and the lymph nodes inside it. So this is an ideal case scenario for a lung cancer surgery because you are basically not handling the disease site, which could be possibly in the nodes. So this is dissection, basically moving en bloc. You can see here in this is the right subcarinal area. You can see we have removed all the tissues en bloc. These are 2R and 4R. This is a highlight area. So this is, at the end, you can see the medias. This is the 2R and 4R. This is the lymph node packet coming out. We can see a lymph node here, but other side we see fat. So inside these fats, you expect the lymph nodes to be present. Again, on the left side, this is the level 5 and 6. We will have a packet. This is a subcarinal area, which is the most difficult side. You can see aorta, esophagus, and it's more deeper on the left side. The recommendation of ISCLC is that minimum 3 and 2 stations should be, minimum 3 stations will be included, and 2 stations, preferably 5 and 1 stations, 10 and 11, and the yield should be about 10 to 16 nodes. So this is, again, a lot of comparison has been done regarding doing a mediastinal lymph node sampling versus medial lymph node dissection in terms of complication time and survival benefit. Are we really doing it justice? So this is the ACOS OG's Z0030 trial published in 2006. You can see that it says very clearly that complete mediastinal lymphadenectomy adds little morbidity to pulmonary resection for lung cancer. So we know that it doesn't add to morbidity. These are the 4 trials to see is there any survival advantage from Germany, Japan, China, North America. And if you see, this is the ACOS one from America, T1, T2, N0, or non-higher N1 were selected after doing a mediastinal load sampling and confirming on frozen. What they found was that if the nodes was negative in intra on frozen, there was no survival benefit for early stage Nsclc. Again, if you compare the whole study from all over the globe, the percentage of case they had was 80% of them were clinically truly stage 1, that is N0. Japanese 80% truly stage 1, N0. German was borderline 60%. Chinese had the least stage 1 N0, more of towards the stage 3A. The Chinese found benefit of doing a mediastinal lymph node dissection in terms of survival. We have to see that in those times, adjuvant chemotherapy was not a standard of care when this trial was being performed. So this may have contributed to the lack of survival benefit in the MNND group because they did not have additional therapy in case the nodes turn out to be positive. So we can interpret that if the lymph node dissection, survival is better if the nodes are truly positive. And if they're negative, it would have never benefited them theoretically. So the conclusion of the cost trial was that since current pre-op staging cannot definitely identify patients with mediastinal lymphoma and patients with known high level of mediastinal N2 disease or those with T3 or T4 tumor may benefit from LND as pre-test possibility of N2 disease higher. So they still recommend that with Nsclc, they should undergo MLND as it does not increase the mortality or the morbidity of the procedure. So the take-home message, the morbidity, mortality is the same. You got an accurate pathological staging, and it has got survival benefit because adjuvant chemotherapy for N-positive disease is the standard of care now. So again, now towards the end about surgery, these are some criteria by ISLC in terms of the completeness of surgery. Surgery is considered to be complete if the microscopic margin is R0. Minimum 3 N2 stations are included, including level 7. N1 stations 10 and 11, the yield should be around 10 to 16. No extra capsular extension if the nodes are removed separately, and the highest mediastinal nodes is negative. Incomplete if it is R1, R2 resection of the margin. EC is extra capsular extension is positive if nodes are removed separately. Uncertain, you've got an R0 resection microscopically but fall short somewhere in terms of inadequate nodal dissection or a positive mediastinal node. I will now go into the recent advances that we have all been waiting and what is currently going on. This is the JCOG 082 trial comparing sublobar or segmental dissection with lobectomy for early lung cancer, the T1 less than or equal to 2 centimeters. This is from the Japanese trial. This was recently presented in the ATS this year. So this is the study scheme, basically clinical stage 1 peripheral Nsclc. Maximum tumor diameter less than 2 centimeters and a CT ratio of more than 0.5. That is a consolidation to tumor ratio. More than 1,000 patients, 1,100 patients were in this study. And this is what they presented. They found that our survival was better in the segmentectomy group by approximately nearly 3%. And in terms of pulmonary function post-op, they did not find a very significant improvement, which they expected to be more than 10%, but it was just 3.5% difference. In terms of relapse-free survival, it was again in favor of segmentectomy, 87.9 and 88%. Sister, sorry. So the recurrence pattern, if you see in the lobectomy arms, it was again, in the segmentectomy arm, there was more locoregional recurrence. So we are saying that you are going to survive more, but you're going to have more local recurrence. So this is very, very intriguing. And we need to further go into details of the study once it gets published. And if you see the cause of death, again, very surprisingly, in the lobectomy arm, there were more cancer cause because of a second lung cancer occurring. That's 5.6 to compare to 2.2 in the segmentectomy arm. But the authors do admit that in the lobectomy arm, the risk factor in terms of cerebrovascular and cardiac was definitely more. So they concluded this is the first phase 3 trial demonstrating benefit of segmentectomy with significant difference in OS. And this result indicates that segmentectomy should be the standard of care instead of lobectomy for patients with small size less than 2 centimeter, CT ratio, that's the consolidation tumor ratio, more than 0.5 centimeter, peripheral C stage 1A Nsclc. They have not included middle lobes in their studies. So this is what was analyzed by many of the experts, and they say this HOG is basically a 3% study. It shows 3% better survival in segmentectomy arm, 3% better lung function, 3% more local recurrence in segmentectomy, but you're going to leave 3% survive longer in segmentectomy, which is a discordance, and there are 3% more cancer deaths in the lobectomy arm. So we need to further go and see into details what is the reason behind more local recurrence in segmentectomy, but at survival advantage in segmentectomy compared to lobectomy. And again, we have got the lung art using the lung adjuvant radiation therapy using the modern RT machine. This is the randomized lung art trial in 2020. They've compared the role of modern mediastinal port in completely resected Nsclc, pathologically proven nodal involvement. 501 patients in the intensive treatment arm, 252 received port, 249 no port, analyzed in 487 patients. They found a DFS of 47.1% versus 43.8 with not statistically significant. OS at 3 years was 66.5 in port and 68.5 in the no port group. They concluded that port cannot be recommended for all patients with stage 2 and 3 Nsclc in terms of the risk of added cardiopulmonary toxicity. It is only in select cases we now apply port, that is R1 resection, multi-station N2 disease because of the possibility of decreasing mediastinal relapse by 50%. So again, this is where is the importance of doing a complete mediastinal lymph node dissection so that we do not leave behind and again add the increased rate of cardiopulmonary toxicity by adding port. And again, coming to stage SBRT for stage 1 operable Nsclc. This is something which the radiation oncologists are not leaving us. And this is the present situation we have is with SBRT for in stage 1. The recommendation is for medically inoperable stage 1 as an alternative to surgery and for those who are not willing for surgery. So this is a revised STARS trial which was published in Lancet Oncology in this year in 2001. This is long-term study of the STARS trial where 80 patients were enrolled comparing SBRT being not inferior to VATS lobectomy with the mediastinal nodal dissection for operable stage 1 Nsclc. They said non-inferiority will be assessed by comparing SABR data of 80 patients with historical institutional data of VATS lobectomy with mediastinal nodal dissection data, which was about 352 patients. And they said SABR will be deemed non-inferior if 3 years OS is not lower than historical arm by more than 12%. And this is what they found with a propensity score match analysis. You can see the OS at 3 years, 5 years, PF at 3 years, and PF at 7 years, almost equivalent 91, 91, 87, 84. So they interpreted that long-term survival after SABR is non-inferior to VATS lobectomy with mediastinal lymph node dissection for operable stage 1A Nsclc, and SABR remains promising for such cases, but multidisciplinary management is strongly recommended. What they also found out in the SABR arm, it was associated high local regional recurrence compared to VATS, 12.5% versus 2.7%, and there was upstaging of the nodal station in about 10% of cases. So we are basically saying our patients in such cases that you're going to live as equivalent as surgery, but you're going to have higher chance of recurrence. So we're going to treat it again, and this is something again very interesting. Now coming to target therapy, target therapy for resectable lung cancers. You can see that this is again we have been talking about target therapy mainly for metastatic disease, but now if we say the target for resectable lung cancer, we have got the Radiant and the CTONG using allotinib and definitive. They have not really stood the test of time. So the present one is basically the Aurora trial, which has been published and has got a good DFS, because of which now even the NCCN has approved it for completely resected stage 1B to 3A EGFR mutant cases. Now presently we have got a neoadjuvant. It is basically osimertinib in the neoadjuvant setting. The trial is undergoing. Neoadjuvant immuno plus chemotherapy. This is basically giving immuno and chemo in resectable cases as a neoadjuvant thing. The study of the single arm of Nadim phase 2 trial for stage 3 was very, very promising with the result of chemo combined with immunotherapy. They had taken 46 patients, out of which 89% had N2 disease, and the majority being multi-station with a resectability of 89%. They reported an MPR, that's the major pathological response, that's basically residual disease less than 10% in about 89% of resected patients, and a PCR, pathological response, in 24 patients. OS at 18 months was very encouraging, about 91%. So following this phase 2 trial, now presently there's an ongoing Nadim phase 3 trial. These are the ongoing phase 3 trials in neoadjuvant setting for resectable cancer. This is what we should be following. Checkmate 816, Keynote 6711, IMPower 030, again, Durvai, we are involved in this study, and Checkmate 077. These are the studies to look for. Oligometastatic Nsclc. This is something very, very new and a good opportunity for surgeons, I would say. The landmark trial by Alcomage showed that local conservative therapy versus maintenance therapy in metastatic oligometatic setting. They found that in this landmark trial, LCT improved the PFS as well as time to development of new metastatic lesions, suggesting either tumor or horror response to suppress the spread of disease. So following this, novel agents have been added to chemotherapy, opening windows of opportunity for surgeons as a part of therapy in local constellation, working along with radiation oncologists for oligometastatic side. So local consolidated therapy, if you see, this is basically for advanced disease and oligometastatic Nsclc. All these are the studies presently undergoing phase 2, phase 3 trials at MD Anderson. We need to look for the Lone Star, Bright Star, North Star. I'll just give a brief about Lone Star. It's a phase 3 study for oligometastatic Nsclc. Immunotherapy is given along with chemotherapy. And if there is non-progression of the disease after about 2 cycles, local consolidation was done using surgery and radiation. Surgery should be preferred primarily for the primary side and radiation for the oligometastatic side. This is again the Bright Star, phase 1 for ALK positive oligometastatic disease. Brigatinib was given for TKI-naive cases. And again, local consolidation was employed for those who do not progress and who tolerate the toxicity of the systemic therapy. Surgery again should be preferably done for primary side, radiation for oligometastatic side. So there's a lot of selection bias in this study, I would say, in the surgical arm, but definitely the surgical has a role. And this is a North Star study. It's a phase 2 for stage 3D or 4 oligometastatic Nsclc with EGFR exon 19 del or L858R mutation, where osimertinib was given for 6 to 12 weeks. And again, in this case, local consolidation was considered for non-progression of the disease, surgery as preferably for the primary side, and radiation for the oligometastatic side. So towards the end, I would say that thoracic oncology, with the addition of better systemic agents, it is definitely opening a new horizon. We talk saying the lung cancers all come at a very late stage, all are stage 4, and 3 and 4. So I think these agents, the novel agents, are opening in new opportunities in the reverse direction that we're going to operate on advanced disease, not early, but doing back from the bottom, that's more advanced disease. So this is definitely a new horizons. And as surgeons, we should be involved in treating metastatic disease. We should not be thinking it's metastatic. It is not for a surgical candidate, because there are some in those who are going to benefit. And this is definitely a big window of opportunity. So thank you very much. I think I've really reached my time. Towards the end, I would like to wish our anesthetic colleagues a happy World Anesthesia Day. I think today is World Anesthesia Day, so I wish them. Thank you. I will now see any questions.
Thank you. That was a wonderful talk. I just remember my time I was in Shanghai Chest Institution. What anybody could learn in 1 year, beautifully, you summarize it. That actually shows the effort you put on preparing this slide. Superb, Darlong, my heartfelt thanks. What a evidence-based talk you gave, right from surgeon perspective, medical onco, radiation. Superb talk it is. I really hope the students know the value of it. I can just know the value of every line slide he has written. bubbling and with evidence, a lot of experience. Superb talk. It's amazing. You should bring a monogram of your talk what you made. It's a excellent guide for every surgical onco student, because I know you run a very big thoracic surgical onco fellowship, and after 3 years of MCH, 1 to 2 year itself is not adequate to master, but you put it beautifully for students. Superb. It is amazing.
Yeah, thank you, Som. I mean, I hope the students really benefited from it.
Absolutely.
Yeah.
No doubt about it. No doubt about it. Not only students, everybody, I think. So there are, if you open the chat box, there are questions. Are you able to see them?
Yeah, I'll just go through. Do we prefer tumor-specific mediastinal lymph node dissection or do we systemic? See, I mean, mediastinal lymph node dissection does not add to morbidity as well as mortality. As I've shown in my presentation, when you do a mediastinal lymph node dissection, it is much easier to take out the tissue. Running after the lymph nodes adds to the bleeding. If you see, you touch a lymph node, it's going to basically break off and cause bleeding. You should try and basically catch the fatty tissue. So when you try and catch the fatty tissue, you are basically doing a lymph node dissection. And this is what, even in the Nsclc criteria, if you are doing if the EC is positive, and if you are doing a sampling or a dissection of nodes, it is not a complete surgery. So, I mean, we should be doing mediastinal lymph node dissection because this is the one we do best. The radiation oncologists can't do it. If you don't do it, radiation oncologists will also come to this site. They are come to the local site. They will now come to the regional site. And one more question, right upper lobe tumor, do we remove station 5 or 6? See, we cannot access the station 5 and 6 nodes. So for right upper lobe, this is basically out of the field. And if on the PET scan pre-op staging, you don't see the nodes there, they're not active, so you don't take those nodes. But if you find the nodes are positive, it's entry disease, so they are not for surgical resection. In case of N-positive disease, do we do VAMLA even post-NSCT or not? And how to manage persistent N+ disease post-NSCT? See, N2 disease is an area of a lot of controversy, and it depends on institution. Some institution, even if N-positive, they basically just stand for chemoradiation. Americans are more towards chemoradiation. If again, European, if you see, they are more towards aggressive towards surgery. In the MD Anderson Center, I mean, even a persistent node, unless it increases in size, it is resectable. They go ahead and resect, and they found about 40% fiber survival advantage. So, doing a resection post NSCT with a persistent node is basically very much institutional dependent and center dependent, and this needs MDT basically for any N2 disease. Right lower lobe tumor reaching up to or within 5 millimeter to right bronchus intermedius. Only right lower lobectomy versus bilobectomy. Which is, see, a margin should be more than 1 millimeter. That's pathological. Microscope should be negative. So for such areas, if it is going to intermedius, I mean, you have to think about doing either a bilobectomy, or if you got expertise, you should be doing a segmental dissection. So you have to basically go above the bronchus intermedius, take the middle low bronchus separately, and do a primary anastomosis with the bronchus intermedius. That's a sleeve resection. What is the definition of oligometastatic disease? So presently, at the present time, we know oligometastatic diseases are basically limited to 3 regions or sites. So there's a lot of variation and in oligometastatic disease. But what we know is that it is, again, center dependent. For oligometastatic disease in MD Anderson, they take the thoracic nodes as one station. 2R, 4R, 7, everything is taken as one station. I think I've answered all the questions.
There are 2 questions. Number 1 question is, sir, how do we interpret a pulmonary function test before a lobectomy? Asked by Vivek.
See, I mean, before a lobectomy, first in your clinical self, I mean, you can really assess the patient. You have the good thing is that when he's sitting there, just see the breath holding time. You got him. Everybody has got to watch mobile. You can just see his performance by seeing the breath holding time. If it is more than, in a rough guesswork, more than 30 seconds, most of the time they should be able to undergo some form of lobectomy. And after that, we go for the complete PFT with a DLCO. A DLCO, anything above 80%, which I've said there, it's indicative, okay, they can basically go for a resection up to pneumonectomy. When it is below 80%, if you see the roughly 2 liters for pneumonectomy, 1.5 liters for a lobectomy, and 1 liter is basically for segmental resection. So to go into this, it will take a whole topic, I think, calculating a PPO, FEVO, and all these things, walk test, stretch walking test, stair test, all these things. There are a lot of tests. So I think it will be a big.
In nutshell, what you told is absolutely should be okay. And Ronak has asked, sir, how do we remove nodes in mediastinoscopy? Ronak, for that you need to see mediastinoscopy being done in a lot of YouTube. If it's not done in an institution, you can go on YouTube. Even on my YouTube channel, I put a very detailed video of how to do a mediastinoscopy and how things are done. It's a special equipment which is available from various companies, including Carl stores. It's very nice, and even you can go on a lot of YouTube. Darlong's video would be there. So you need to look at it, but you want to add anything? How lymph nodes are removed in mediastinoscopy?
See, in mediastinoscopy, you need a video mediastinoscope first. And beyond that, again, once you have mastered it, you go for the VAMLA. I don't do the VAMLA. These are basically very, very highly specialized skill technique. Zelinsky does it. We know he approaches everything from the mediastinum right up to lobectomies. So what's important is that you should get in the right plane. That is the pretracheal fascia. That's the most important. The position, the neck should be extended, and you should be reaching in the correct plane. That's a pretracheal fascia. You get anywhere beyond that, you are basically going to be in the mess. So once you are in the pretracheal place, initially it's a blunt dissection. Your finger goes in there, make space, then you put a scope, then with the instruments you start dissecting of the facial layer off from the trachea. Then you can basically, so it's very difficult to explain basically exactly how,
you can go on YouTube and watch it. On my YouTube channel, I have put detailed procedure steps of mediascopy, or a lot of many other people, very good one are there. You can go, then you'll understand, or you can watch it in your center, nearby center. Good. I think all good things has to come to an end.
Yes.
This is a topic which is double MCH. I have to tell you, after I did my MCH surgical onco, it took 4 or 5 years to master, to go to China, Shanghai Chest Institute, everywhere to learn. Even now, there's million things to learn. Maybe all of you students, once you're all done, drop down to Rajiv Gandhi. Spend few days as an observer at his convenience when it's available. It's the most fascinating field, most challenging field, underutilized, underdone, and very good quality work is required. It's in number. India, you can count in numbers people who are very good thoracic surgeon like him who do with passion. But this is a beautiful field for a student to take it up. It's just a tip of iceberg. It doesn't get covered in 2-3 years. It takes a lot of time to master. But what I personally thoroughly understood the value of each slide. I really wish all the students who are logged in know the value of this talk. Coming from somebody who has thoroughly read everything in the back of mind, and putting it in a nutshell for a surgical onco student is very difficult to do. But it is done so well. You exceeded my expectation. Nobody came to my mind when this topic came, and I'm so happy. You could oblige and take a time out of it. On behalf of all the students, from their heart and my heart, I convey my wishes. We can't give any gift for such a beautiful talk. The best wishes of all the students, and eternally they will remember you after they complete their exam before, is all that can carry to you and your family. Even though very nominal honorarium NBE and Navneet Singh ji sends it, it is more of a honor. We know that the value of that is honor. Thank you very much. You can see even our chat boxes are flooded with thanks. Thanks very much. It's a superb talk. Heartfelt thanks. Thank you very much.
Thank you so much, and very much congratulations for such a nice event you're organizing. Students are organizing a lot. Okay, bye-bye.
Thank you. Over to Navneet Singh ji.
Thank you very much, Professor Darlong, for the presentation, and thank you very much, Professor Dr. Somashekar, for joining us. And thank you, trainees and faculty members, for joining us.
Thank you.